Okay, so I'm Barbara.
I'm Chloe.
I'm Iris.
I'm Catherine.
And I'm Leah. And we are the Hip Doctors.
Now trending on social media. We've looked at Instagram and Twitter. #Labral tear. Dancers that are at risk for developing groin pain that is caused by acetabular labral tears. So here we have a video of a ballet dancer doing an Italian fouette. She's showing external rotation and abduction. It's a commonly associated movement with labral tears.
So our case is a 16-year-old ballet dancer who comes into the clinic complaining of persistent hip pain over the past 6 months. She describes a locking sensation with occasional loss of stability. Her symptoms worsen with activity, and her desire is to return to activity as soon as possible. She's wondering whether surgery is her best option. What do you recommend? Our learning objectives are, number 1, to describe the structure and the function of the labrum in the hip joint. Number 2, to identify mechanisms of injury for an acetabular labral tear. Number 3 is to describe the process of diagnosing an acetabular labral tear. Number 4, describe the location of symptoms and 5 symptoms indicating an acetabular labral tear. And number 5 is present 2 treatment options supported by current evidence. Which brings us to our first question.
What is the labrum? Is it A, a ligament, B, a cartilage ring, C, a tendon, or D, a bone?
Did you say cartilage ring? You were right!
The anatomy of the labrum. It is a fibrocartilaginous ring that is attached to the rim of the acetabular socket. It's made of thick type 1 collagen fiber bundles that run in parallel, so around the acetabulum in circular parallel with the acetabular socket. It's triangular in shape and thins as it goes to the anterior portion of the socket, and it's innervated by branches of lumbosacral plexus, which are innervated with free nerve endings that are sensitive to pressure and pain in the anterior and superior portions of the labrum. The greatest vascular supply is to the outer 1/3 of the labrum, with the inner 2/3 potentially avascular. Function acts as an extension to the acetabulum, which deepens and extends the socket by 21% and 28% respectively. It increases surface area by allowing greater distribution of contact forces, so more pressure distribution around that joint area. And it also improves stability of the joint, resisting lateral and vertical motions of the femoral head within the acetabulum. It also produces a suction effect, so it keeps the joint in place. It allows for retention of synovial fluid, so it also lubricates the joint as well. Our next question. Okay. Next question.
Why is a posterior labral tear not likely to heal? A, it is avascular. B, it is full of cobwebs. C, it is thinner than the anterior. Or D, it has a better blood supply.
If you guessed avascular,
you were right. Which brings us to the classifications of labral tears. Labral tears are classified based on their location, morphology, or etiology. Location of a tear can be anterior, posterior, or superior lateral. And their morphology can be a radial flap, where there's a flap of tissue that's been separated, radial fibrillated, which is where the tissue's been kind of torn apart, longitudinal peripheral, which is a long longitudinal tear, or unstable, where there's multiple tears within the labrum. Which brings us to our etiology, which is related to the mechanism of injury, which is on our next slide. So there are 5 identified mechanisms of injury as per Kelly et al. 2005. Number 1 is a direct trauma to the labrum. Number 2 is a femoroacetabular impingement, or an FAI. Number 3 is hip hypermobility. Number 4 is dysplasia, or number 5 is degeneration. Tears occur most commonly in the anterior or anterior superior aspect of the labrum and are often associated with dysplasia or structural deformities. Increasing age is a risk factor for deterioration as it relates to number 5, which is degeneration of those tissues. Labral tears are also commonly associated with additional localized chondral damage, such as chondromalacia, which is thinning of the cartilage, delamination, flap tears, or deep damage causing exposed bone. Repetitive external rotation and abduction movements have been shown to induce increased strain on the capsule and the labrum, which brings us to our third question.
Which movement is most likely to cause labral tears? A. Adduction, B. Internal rotation, C. Extension, or D. External rotation and abduction?
Did you say external rotation and abduction? Because you were right. To relate these mechanisms of injury to our case study, we looked at mechanisms for dancers specifically. Dysplasia and structural abnormalities are not often reported in elite dancers, as they would have self-selected at a younger age. So what we're focusing more on is the external rotation and abduction movements, which are very common in ballet. These extreme ranges of motion, pivoting movements, and repetitive compression forces in dance suggest frequent FAIs and degeneration of the labrum as the most likely mechanisms.
The pain that is associated with labral tears may present in the anterior hip or the anterior groin. Less commonly, it may present in the posterior buttock. Mechanical symptoms of a labral tear include locking, clicking, catching, giving way, and stiffness. These symptoms will worsen with long periods of sitting, standing, or walking. In addition, you may see a limp or Trendelenburg sign. You can see here the passe position, which is commonly used in dance. It is commonly associated with pain in those with an acetabular labral tear. The patient presents with pain in this position, among others, as well as a locking, clicking, and a giving way sensation. The pain is anterior with a sense of radiating down the thigh towards the knee. So how do we diagnose a labral tear? It's difficult. You would begin with a history. Is there a history of known trauma associated with the hip pain that is presenting? We move on to a physical examination, commonly doing a test for an FAI. This is often positive when a labral tear is present. Arthroscopy is the gold standard for diagnosis, but the best non-surgical option is MRA, or magnetic resonance orthography. Contrast dye provides a view of the tear as well as any bony irregularities that may be present. It's very common to go undiagnosed for a long period of time, over 2 years on average, and 55% of patients who present with mechanical hip pain of an unknown etiology will eventually be diagnosed with a labral tear. Which brings us to our fourth question.
What is the best method to diagnose a labral tear? A. X-ray, B. YMCA, C. MRA, or D. Ultrasound?
Did you say MRA? You are correct.
After a positive FAI test, the patient undergoes an MRA. The MRA is positive for an anterior labral tear with the radioflap morphology, such as you can see in this diagram. However, no other structural abnormalities are seen. Typical non-invasive treatment includes limited weight bearing, NSAIDs, and sometimes physical therapy. However, if this non-invasive treatment does not improve symptoms, surgery is often undergone. Surgery often shows good results in the short term, but longer term results are unknown. Arthroscopic surgery is the most common procedure, and studies have demonstrated mixed results about patient satisfaction after the procedure. Patients who have persistent pain for longer than 4 weeks are candidates for hip arthroscopic surgery. Recent data suggests that athletes who undergo early intervention, less than one year from the time of injury, return to sport quicker than those who wait for longer than 1 year to have surgery.
So I'm just going to go over some evidence for the benefits of arthroscopy. There is some evidence of positive outcomes for treatment of symptomatic tears with partial arthroscopic resection of the torn part of the labrum. In one study, following the outcomes of 50 patients, they found a significant decrease in clinical symptoms associated with labral tears in a 2.8-year follow-up post-arthroscopic surgery. There's another study as well, looking at arthroscopic treatment of labral tears in dancers specifically, and they found a high rate of success. They looked at 30 dancers post-surgery and found statistically significant reductions in pain and increases in function and returned to dance after a 5-month follow-up. Oh, and our last question. Okay.
There is some evidence that arthroscopic surgery can decrease pain and increase functionality in patients with a labral tear. True or false?
If you said true, you're correct.
All right. In conclusion, this case study examines a young dancer with a suspected acetabular labral tear.
A treatment plan that involves conservative measures such as limited weight-bearing NSAIDs and physical therapy, including postural adjustments during specific ballet movements, has been recommended.
This conservative treatment plan is recommended based on the location of the tear in the anterior and better vascularized region of the labrum.
Arthroscopic surgical intervention, debridement of the tear, will be recommended if symptoms persist without improvement for 12 weeks or will be considered sooner at the request of the patient.
References!